Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is A Fracture in the Main. These are my potential conflict of interest. The patient I would like to present is a 68-year-old male presenting with ST elevation myocardial infarction and a chest pain lasting for 2 hours. He was previously treated for hypertension, dyslipidemia, and diabetes. On presentation, he was hypertensive and tachycardic with slightly decreased LV ejection fraction with some regional wall motion abnormalities. He had a fever 2 days ago, but he tested negative for COVID-19 and he stated that had previous renal failure. On ECG, you can notice an ST elevation in AVR lead, but also there's a striking ST depression in D1 and precordial leads. On initial angiography, there's a long calcified lesion in proximal and mid segment of the right coronary artery, but you can appreciate a critical lesion in the left main stem of the left coronary artery. More coronary angio showed that left main was stenosed in a distal segment with preserved flow and without stenosis of the ostial segment of the LAD and circ. We don't usually do scoring when we have a patient in acute coronary syndrome, but in this patient, right coronary artery gave 10 points and the left main 14 points, which yields 22 points in syntax 1 score. Syntax 2 stated that there's an equipoise between suggested treatment of PCI and CABG, and the surgical Euroscore 2 yielded relatively high mortality due to urgency of the procedure and an ongoing ischemia. Recently developed Syntax Score 2020, which used the data from the Syntax trial and another 3 trials that analyzed patients with multivessel disease, showed that there's a slightly higher mortality with PCI and MACE events compared to CABG. And now, none of these studies have not taken into consideration patients with ST elevation myocardial infarction, and previous generations of drug-eluting stents were used, and most of them have never used imaging in the procedure. So the question is what to do with this patient. There's an option of PCI in the same procedure, or send patient to surgery, do heart team analysis, or just wait and see what will happen. We've decided to do the PCI in the same procedure, and we pre-treated patient with DAPT, used a radial access, and placed workhorse wires in LAD and circ, pre-dilated the left main and LAD with non-compliant 2.75 balloon, and then implanted Synergy 3.5 times 24 stent. The pump was done using 4.5 NC short balloon. And the result was relatively okay regarding proximal LAD. We used a provisional strategy, but there was a sluggish flow and an incomplete opacification in the left main, pointing towards something was not okay. We decided to do stent boost, and unfortunately, based on this image, you cannot easily discern whether this is stent distortion, fracture, underexpansion, or breakage. So we've decided to do IVUS. Despite relatively preserved lumen and diameters, there was a gross malapposition and incomplete expansion of the stent in the LAD and also in the left main. But you can also notice a very calcified lesion that takes up to 180 degrees of circumference and an incomplete apposition of the stent in the left main. We've decided to repeat proximal optimization and also to do a distal optimization with larger non-compliant balloon, and then implanted short, large diameter synergy stent 4.5 only in the in the left main, and then repeated part with 5.0 NC balloon. We repeated stent imaging, and as you can see that there is a well-expanded stent in the left main and LAD, and on the angio, the flow looks good and the expansion of the stent looks relatively okay. Also, in another projection, you can appreciate that the ostial segments of the circ and LAD are without significant stenosis. We repeated IVUS, the diameters and the cross-sectional area were greater, and you can see that there is an optimal, or I say adequate, expansion of the stent in the left main. And the patient stayed in hospital for 3 days, and it was seen 1 month after the procedure, doing okay. And we scheduled repeated PCI of the right coronary artery and angiography, and probably imaging of the left coronary artery. But what has to be done now is to do a stent distortion analysis in this patient. We use Synergy platinum chromium stent, which is thin strut stent with abluminal polymer and sirolimus as an antiproliferative agent. And this stent comes in various diameters, and for the large vessels, it has 10 crowns and reinforcement of 2 to 5 connectors. As in bench study, this stent can be expanded up to 6 millimeters, but what can be compromised is the radial strength and adequate scaffolding of the very calcified left main in this situation. And also, imaging in acute coronary syndrome can and should be used, because risk of using imaging is smaller than the risk from suboptimal procedure. It can be initiated at any point during the procedure, but the results should be interpreted cautiously. This is my presentation, and I'll thank you for your time.